I'm Nadia Shafiq, Assistant Professor and Department of Psychology, University of Islamabad. So good morning to our US colleagues, Dr. Meghan, and good afternoon to our UK colleagues, Jill and Dr. Saida. So hi everyone, good evening to Pakistani colleagues now. So it gives me an immense pleasure to welcome you all to the post-conference symposium to shed light on the current trends in intellectual disability. The prevalence of intellectual disability is reported to be 8 times higher in low-income countries than in higher-income countries. And Pakistan has high rates of intellectual disability, which is very alarming. So we are very fortunate to have eminent speakers from the USA, UK, and Pakistan who will highlight the management of intellectual disability, the disparity in the services of intellectual disability, and their agony of life. So first of all, we all start our session by the name of Allah Almighty. So I would like to call Mr. Umair for the recitation of Holy Quran. Over to you, Umair, please.
Thank you, Ms. Nadia. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والله أخرجكم من بطون أمهاتكم لا تعلمون شيئا وجعل لكم السمع والأبصار والأفئدة لعلكم تشكرون. Translation. And Allah has created you from the wombs of your mothers while you knew nothing and gave you ears and eyes and hearts so that you may be grateful. तर्जुमा. और खुदा ही ने हमको तुम्हारी माँ के शिकम से पैदा किया कि तुम कुछ नहीं जानते थे और इसने तुमको कान और आंखें और दिल और उनके अलावा और आज़ा बख्शे ताकि तुम शुक्र करो. सदक़ल्लाहुल अज़ीम.
So I'm getting support from my co-moderator, Ms. Aisha Khali. She is with me during this session. And this session will be chaired by Professor Naseem Chaudhary, Chief Executive. So I'm really honored to introduce Professor Dr. Naseem Chaudhary, who has received intensive training in learning disability from Medbro Unit of Psychological Medicine, Royal Bolton Hospital, Burnley General Hospital, and the University of Manchester, UK. She is a member and fellow of the Royal College of Psychiatrists, UK. Currently, she is serving as the Chief Executive Officer of Pakistan Institute of Living and Learning. And she is an honorary professor of psychiatry at Dow University of Health Sciences. She is the head of Psychological Medicine's Remedial Center Hospital and Associate Director of Global Mental Health and Cultural Psychiatry Research Group. She has contributed greatly to spreading awareness about intellectual disability by establishing the first Learning Disability Research Center at Pakistan Institute of Living and Learning, where she conducts awareness, community events, and workshops. She has paved the pathways to care for persons with intellectual disabilities by liaising with relevant stakeholders. She has to her name several peer-reviewed publications of women's mental health, dementia, intellectual disabilities, self-harm, and suicide prevention in low-income countries, as well as literature in cultural adaptation of cost-effective psychological therapies. Thank you so much, Pam, for your contribution in this field. And with your support, we are progressing towards this. We are truly blessed to have you. So ma'am, I would like to invite you for an opening remarks.
Thank you, Nadia. Thank you for your very kind introduction. I'm extremely excited and really looking forward to this very important symposium. We've got 3 great speakers and some fascinating topics. I would like to welcome, to begin with, all our participants and speakers on behalf of my organization, Pakistan Institute of Living and Learning. And just a very brief update on intellectual disabilities in Pakistan. So we have one of the highest reported cases of childhood intellectual disabilities. For severe, 19.1 per thousand, and 65 per thousand for mild intellectual disabilities. A census, adult census done in 1998, reported the prevalence of intellectual disabilities to be around 7.8, which even at that time was thought to be very low. Clearly, we know that the prevalence is higher than this. We have very fragmented, limited, existing system of care from local or our federal governments. There is a delay of approximately 3 years from detection to seeking help. We don't have a state structure of transition from children to adult services. We do have some fantastic not-for-profit organizations that are running limited special education schools, and there are some state-run special education schools as well, but they are far and few, and there is nothing once they reach adulthood. There's lack of research, limited services, stigma. So the brunt falls upon families to look after children, and then when they become adults and when they are old. And mostly they end up using chemical or physical restraint for management of behavioral problems, which can include use of medications, tying them with ropes, with chains, or at times locking them in their rooms. We know that people with intellectual disabilities have high rates of mental illnesses. They have multiple physical comorbidities, but it's not something that's taught in our medical schools. Our postgraduate psychiatry training does not include intellectual disabilities. So clearly our doctors, our psychiatrists are not equipped to understand the issues, how to communicate, how to assess when people are presenting with difficulties and they've got an intellectual disability. In a population of over 230 million people in Pakistan, I think at the most we would have 2 or maybe 3, I'm not even sure of that, psychiatrists trained in intellectual disabilities. Our organization, spread across Pakistan, mostly focuses on mental health issues, well-being of people of Pakistan. We have a research focus. And like Nadia said, we have established this neurodiversity group because we want to set and develop a framework of research in Pakistan. And all our 3 speakers, in one way or the other, are contributing to this cause. So a big thank you from Pakistan to all of you for supporting us in this. I'm going to not take a lot of your time. So back to Nadia, so we can start with our presentations. Thank you, Nadia.
Nadia, you're on mute.
I'm audible, please. And I would like to introduce our first speaker, Dr. Sada Hussain. She is a very talented, creative, dynamic, and incredible personality. Her background is showing her creative work. So Dr. Sada Hussain is a consultant psychiatrist in intellectual disability in Northwest Deanery Health Education. She is a representative community for intellectual disabilities trainees Northwest and lead organizer for Northwest Learning Disability Academic Regional Teaching Forum. Saida has been chairing, organizing teachings both at local and regional levels, presented in national and international forums. Her work involved in multiple research and quality improvement projects across the clinical and educational landscape. She has been the part of advisory research groups, both national and international. Her publications include in LD, autism, service evaluation, as well as in medical education. She is actively involved in promoting intellectual disability psychiatry by presenting and motivating core trainings, by participating in MRC career workshops at local and regional levels, and contributing to medical school career events and virtual career sessions. She has become a valuable part of intellectual disability faculty recruitment team, working closely with faculty members to improve recruitment and retention for intellectual disability and psychiatry. In her many accomplishments, Saida has become a finalist in the Inspirational Leadership category in the Canine Care People's Award in 2019. In the same year, 2019, she was awarded the accolade of High Trainee of the Year by the Northwest Royal College of Psychiatry. So wonderful work you have done, mashallah, Saida. So we are really grateful to you for sparing time for us. So now floor is yours.
Thank you so much, Nadia. It was such a kind introduction. Really appreciate that. Are you able to hear me well? Yeah? Can you hear me well?
Yeah.
All right. Okay, great. So yeah, thank you so much, Nadia. It was a great introduction. Thank you. I feel very overwhelmed. So I'll be talking in the next 25 minutes about the introduction to intellectual disability. So the term intellectual disability is used sometimes as learning disability as well. So there are both the terms you will see in my slides. The main idea of today's presentation is about understanding what intellectual disability is and what's the complex case management processes which we can help and support the individuals who have needs and how to identify them, as Dr. Naseem suggested about how difficult sometimes it can be. So we will be revisiting the definitions of learning disability and challenging behavior, but also I'll be sharing some understanding about the complex case management in individuals who have intellectual disability. And we will be using a CALM framework, which I have been practicing and very fortunately doing a number of quality improvement projects to improve understanding, not just the MDT professionals or the professionals who are looking after these individuals, but also the educators and other learners who are just starting to be psychiatrists or our future leads. So what means someone has a learning disability? And this is very important to understand what means someone has learning disability, because if you do not understand their needs, what it means to be, then we are not able to provide the right support and help. So the category of learning disability has three components within the Mental Health Act in England. So it comprises of a state of arrested or incomplete development of mind with significant impairment of intelligence and with significant impairment of social functioning. So if we see each component, we have to understand the criteria around each component, but also each component reflects the needs and problem areas in that individual. So if you think about the state of arrested or incomplete development of mind, so in that case, the patient should have a significant impairment of the normal process of maturation of intellectual and social development. So it has to include both the sides, but that occurs during the childhood and adolescence. So we wouldn't use the term for categories where person is developed normally and then lost milestones of development. And we see quite often this term in people who have traumatic brain injury after 18 years of age. And it's a very important thing to identify what happened, when happened, and how happened. So you can see a number of concrete scores here, which shows and help us to identify the level of learning disability or intellectual disability. But again, the code of practice is absolutely clear not to rely on these rigid scores. For example, the cutoff of 70. The reason is that, for example, if someone has IQ around 72, but the rest of developmental history suggests that the delays in maturation development milestones, then the IQ doesn't rule out learning disability. And similarly, if someone has normal social and adaptive functioning, but his IQ is too low, that again doesn't rule out the diagnosis of learning disability or intellectual disability. So we do have those concrete scores, but it's about understanding the needs, and it's about the understanding of functioning and the adaptive behavior. So the third component is about significant impairment of social functioning. So how individual adapts to the demands of day-to-day life. And there are three important components here. So thinking about their practical skills, is he able to maintain the household demands? Is he able to look after himself, like washing, cleaning, self-care? How the individual manages his finances, how the normal day-to-day functioning are happening. But also it's about the social functioning, which means how he's able to interact with others in terms of social situations, social participation, how the communication looks like, how the environment looks like, what sort of interests and strengths he has to develop his life. And then the third is about the conceptual skills, about the conceptualizing the plans, for example, budgeting, day-to-day functioning, planning a journey. So how is he able to execute those plans is very important. So all these three aspects are important, but if you're thinking about the framework in UK, what it means in a code of practice. So someone with learning disability may not be detained for assessment unless the learning disability is accompanied by behaviors that are abnormally aggressive with seriously irresponsible conduct. So we have to think very closely about if we are taking someone's liberty, if we are producing the restrictive practices, we have to understand to qualify abnormally and seriously. And the code of conduct practice says to rely on nature, circumstances, and the risk associated with the behaviors or act to decide whether something is abnormally aggressive or seriously irresponsible. So again, you have seen a number of terms here, very, very big terms, but just think about the term behavior. And we'll quickly talk about the challenging behavior. But before that, we have to be very clear about that learning disability or intellectual disability is not learning difficulty. So you may have seen this misconception that patients do sometimes come with learning difficulty, refer to our services, and we are asked to provide help and support, which we would really happy to. But we have a very specialist service. So we are the service who are providing care and support for people who has all those three components. And problems with reading, writing, and learning difficulty is not learning disability. So it's a very important thing to make sure that how we are influencing our functioning of day-to-day services about all these things. Again, emotional difficulties that may have disrupted their schooling or may have influenced the achievement of the individual. Again, it's not learning disability. Conditions like autism, ADHD, other mental illnesses, again, they may cause changes in the lifestyle. They may cause changes in the social participation. They may have outcomes like communication problems. But again, this is not learning disability. And the disability resulting from brain trauma or having a culturally different lifestyle, again, is not learning disability. So we have to be very clear what means someone has learning disability. Then we are able to provide the help and support, and the case management can be developed. So what it means someone having a challenging behavior, and this is the term we have seen a lot of times in our society, behavior is challenging. And for me and for us as professionals, it's not the behavior which is challenging, it's us or our environment is challenging, or things which are happening around that individual can be challenging. And we have as individuals, as professionals, needs to identify how to improve the life of those individuals. So the behaviors which are in the form they are trying to communicate, we try to understand what's the story behind that behavior, what they are trying to say, what sort of things they are trying to tell us that things are different now and they need help. So the Royal College of Psychiatrists has adopted the definition by saying that behaviors can be described as challenging when it is of such an intensity, frequency, or duration as to threaten the quality of life or the physical safety of the individual or others, and is likely to lead to responses that are restrictive, aversive, or result in exclusion. So again, think about those particular terms, which are really big terms, but we are trying to restrict someone. But do we know why we are trying to restrict? Do we know, is he in the right environment? Do we know, does he have any needs related to communication? Does he have any needs related to physical health? Or is it ongoing mental health problem going on? So you have to be very clear about all those things to restrict someone around those exclusion criteria. So again, as I said, it's a very complex interaction because sometimes intellectual disability do comorbid with mental illnesses, but a lot of interaction between the autistic spectrum disorders, because they look a lot like together, but they are very different to provide care and support. So how to improve understanding of professionals and individuals looking after them about their needs and problem areas. They're also about the physical health and other challenging behavior part of those complex interactions. So I put this here, some individual and environmental factors, and you can see number of factors, as we said, can be because the patient is or the person is behaving that way is because of those difficulties. We have seen individuals having a lot of sensory disabilities and sensory difficulties, and because of that, they may be distressed and their arousal levels are high and their behaviors looks like very challenging to the people providing care. But if we understand their sensory needs, if we understand their environmental needs, if we understand the way their physical health or mental health is working, we will be able to support them and help them to reduce those behaviors, to reduce those arousal by providing right support. Again, there are a number of environmental factors which may be considered or should be considered very closely in not just our learning disability specialist services, but any service which is with the mental health, to think about how the environment looks like, how the people around the person looks like, how the needs and strengths of the individual is affecting those outcomes. So there are a number of factors that influences the case management, and it's about understanding the right aspects of care and to produce a good risk assessment and management processes, to thinking about the specific therapeutic interventions towards the problem areas and needs, and about how we can streamline the case management by supporting the teams, families, by providing the consultation and enrich support for those individuals. So next 10 minutes, I'll talk about CALM, which is I'm very much close and practicing from last 2.5 years. So CALM stands for Complex Case and Recovery Management Framework. It's a framework practiced in Mercy Care and also in specialist learning disability teams. And it's a system of framing the functional formulation and intends to complement other kinds of formulation, including psychology or psychiatry perspective. So it's a really good framework for assisting and enhancing the understanding of complex case management for people with intellectual disabilities and autism. And by becoming part of it and becoming a lead or chairing number of quality improvement projects, now part of self-guided CALM project, complex case management workshop project, we're bringing to the people as an internet-based intervention, which has been successfully practiced within the specialist services and MDT professionals, and also on the educational forums. So what's CALM? So the CALM concept is about individual. So think about the person rather than everything else. Think about who that person is, what this person looks like, what his needs are, what his strengths are, and how to produce, how to add value by improving the circle of support and by improving the social participation. So it has 6 value themes, which are all highlighted in yellow. So it's about how to build a circle of support, how to develop a shared understanding of the predicament, how to capture the problem areas, which I'll define, how to improve social participation and introducing living a good life model, how to keep people safe, not just himself and others, and how to understand if we are making progress. And that's the most important part, because sometimes when we are winning, we always stop and we always think about, okay, things are going well, and things can be easily dislocated after that. So how to understand why we are making progress, are we winning, losing, or holding, and how to review that progress again and again to evaluate the process, that there is a strong care coordination and case management plans. So the first theme about how to build a circle of support. So circle of support means what support, what networking, what patient has within their family and friends, but not just family, but about the care and support by the staff teams, but also about the secondary care services in the form of specialist learning disability teams or other mental health teams, or maybe physical health teams. So for example, most of our clients, or at least 50 to 80%, have comorbid diagnosis of epilepsy. So how we are improving and how we are adding people to improve their needs and problem areas by improving their circle of support. So this workshop and this framework helps to develop collaborative work with the individual and generating a value together with the teams who make and add value. So it's not about adding so many people, but it's about adding the right individuals for the support and needs. And as we said, it's about that individual and that person. The second theme about developing a shared understanding. Again, a shared understanding to what extent people are talking the same language. So the same language, it doesn't mean the language about very professional and labels. The language means, do we know who he is? Do we know the individual needs are? And to what extent the shared planning, the shared formulation, and shared understanding of the needs related to the risk and diagnosis are shared among the people who are looking after the individual. Because sometimes we have seen a lot of dislocation happens because different teams have different perspectives about the care of the patient, or maybe it's not very much coincident with what family feels about that patient. So it's bringing people together to talk about how to improve the understanding of the risk, how to improve the understanding of the care planning, and how to improve the language to be shared among the individual and the family members. The third theme is about capturing problem areas. And again, problem areas doesn't mean a problem area. It means that patient may have number of diagnoses, but what is exactly our worry about that patient or an individual? So it can be related, if the problem is related to physical health, or if the problem is related to mental health or environment. So rather than labeling about too many difficult terms, for example, depression, schizophrenia, or personality disorder, why not to think about each problem related to the diagnosis? So for example, if someone hears voices, rather than talking about schizophrenia, how to help and support the individual for hearing voices, how to support the individual for having a structured day, how to support the individual about having some other, to develop his strengths and to make sure that he's not overly aroused, so that rather than medicating too much, why not improve his life and improve his social participation? Then the fourth thing is, as I said, about social participation and living a good life model. And it's really important to understand what individual needs are in terms of his interests. And thinking about the strength and interest can sometimes bring a lot of changes. Improving understanding of the day and the structure and the themes, improving understanding how to improve his communication. And here our MDT professional really plays a big role. For example, our occupational therapists think and talk about how to improve the structure of the day. And then he also think about, oh, is the right environment there? Or is there sensory considerations are taken into very much consideration, because it's very important to understand their sensory needs and environmental needs. And here also our colleagues from speech and language therapists, they may can contribute understanding about the communication. So having a good communication profile, having a good structure of the day can improve number of things, a number of problems which looks like challenging to the teams and individuals. And the very important part of it is about how to keep people safe. So it's not just about keeping people safe for themselves, but also about the others, for the public safety. And to have this theme as a workshop, as a framework, it's about developing dynamic understanding of the risks and capacity around each problem area. So if we identify 3 or 4 themes or problem areas, for example, if someone have problems with physical health, or maybe there is a history of trauma, or maybe there's a difficulty ongoing with the emotional coping and day-to-day functioning, or maybe they have sensory or communication needs. Do we understand why we are worried about all those problems? Do we have any risk mitigation plans towards each problem? And how we are assessing the capacity, the individuals inside about those problems? Because without involving the individual, you can't bring change for that individual. And the last but not the least is about making progress and moving on. And again, this is very important, as I highlighted, how to regularly review the case management process. And in England, we have frameworks like CPAs, peer treatment reviews, and multidisciplinary team professionals meeting. But this framework also highlights the importance of care coordination. So someone who is in between all of us to coordinate the care, to make sure things are going well, but there might be times when things may not go well. And that's the time we have to gather early to develop some ideas about the risk management and case management. So the calm for each theme, we discuss about the areas of strength and always talk about the best side of it, what's going well, what things are going well in individual's life. And every individual has something going well in terms of their strengths, in terms of their families. Then we have to think about what are the concerns and what possible fresh approaches we can identify. So subsequently, the workshop on the framework helps in highlighting the significance of collaborative care plans among team professionals. So during the recent lockdown, for those with complex needs, with intellectual disability and autism, it was difficult for people to source timely support for themselves. And also, as we all are aware how COVID happened, and we were not able to provide the same support, because this is the very vulnerable category where they started having self-isolations, and they are still very much less with the face-to-face consultations. So we have started a number of quality improvement practices for the purpose of enhanced care delivery and improve patient outcomes during COVID pandemic. And I'm very fortunate to lead with Dr. Mark Sperrell, who's the author and who's the start of this CALM framework with Lauren in Mercy Care, the self-guided CALM program, which was introduced, adapted in a practice as a basis for online workshops to reframe case management for people with intellectual disability and autism. And it was a really good platform in a psychologically safe environment to talk about multidisciplinary team professionals, carers, and staff to think about how to refresh the whole thing, how to reframe the problems, and how to support the individual at the time of need and crisis. Again, we also have developed, myself and Dr. Sperrell, we have developed a complex case management workshop for trainees and trainers, and we have completed the first cycle as part of our regional Northwest LD training forum. And this has a lot to do with enhancing the understanding of case management and complexity and pathways among senior trainees and early career consultants. So the project has highlighted the significance of foot-based management for bringing change and adding value for people with intellectual disability and autism. So this has been shared last year in International Congress and this year as well in the upcoming Congress. I'm fortunate to become part of a Congress in Denmark to produce as an oral presentation, but also about how we are sharing about the complexity, how we are addressing the needs, and how we are supporting individuals who are living with those people who have difficulties. So again, there are some useful resources and references to my paper and also for the NHS England in terms of STORM, Transforming Care Agenda, and NICE guidance. And thank you so much for listening to me, and I'm very happy to take any questions.
Thank you so much, Saida. Thank you for giving an overview of intellectual disabilities. I think that's very important. And then taking us through this amazing framework. I've got questions in my mind, but yeah, we've got Hina. So Hina, do you want to share your question or comment?
Hi, everyone. My name is Hina Mirza. I'm a GP trainee in Birmingham, UK. And so nice of Asma to invite me in this meeting. Thank you so much, Dr. Asma. I have, few questions because I'm from Pakistan originally, and I want to ask a question because you started with the introduction. I mean, the thing is, learning disability or intellectual disability is a new thing in Pakistan. And how it can be I think the main thing is the care given to the patient, how we can implement that.
Now, thank you so much, Hina. We are, Professor Naseem and we as a team working to improve understanding. So it's a long journey. It's just started. And I think Professor Naseem can also highlight that. It's about understanding what needs and supports we can provide. And there are a number of researches and systematic reviews are going on to understand what frameworks have been used in other low socioeconomic countries where this framework is not there. So only UK has got specialist training for 3 years. We are still very lag behind, not just Pakistan, but in America, Canada, and all other places. There is only 6 weeks placements in specialist services for learning disability for the psychiatrists who are the future leaders in those countries. So we as Pakistan still have some background, some research has already started to understand how we can improve the social participation. And your question is absolutely right. We are lacking in terms of social participation, social support in our individuals in Pakistan and other countries. And this type of framework may introduce, but it may take a bit of time, isn't it, Professor Naseem?
Absolutely, absolutely. Do you want to finish, Saida, and then I'll add a comment?
So this is something to think about. If as I said, every individual is different. So if we do rather than everybody, why not to talk about one individual at a time, and then think about how we can improve the network and how we can improve the support and how we can improve the case management. And while doing that, we may need a bit of few years, but at least we are in the right space and right initiation, isn't it? So I'll leave it with you, Dr. Naseem.
No, I was saying that it's a very relevant question because prevalence of people with intellectual disabilities is high in Pakistan, but there's little awareness. And I think this framework because we, in terms of our organization, we, I think, excel and we've got a lot of expertise and experience in adapting interventions according to in our language and our culture. So maybe CALMS is something that, Saida, that we and with Dr. Spurrell, that we think about how can we adapt it with keeping the family, because our main carers, we don't have the MDTs, we don't have, so it's the families that are our main support structure. And probably we'll hear more from Megan in terms of services as well. And that's but this is something for a later, but again, definitely something that we must think about. How can we incorporate this, educate our families, same themes, same areas, to support and help them and make it easier for them. And maybe look at introducing some form of training in our medical schools and our universities. So I'll just see if we've got more comments or questions. I'd like other people share their comments. Anybody else?
I want to just say one thing. Asma, very good presentation. Thank you so much.
Thank you so much for doing it.
So are you Asma or are you Saida?
So my middle name is Asma. So
Okay. Okay. So, I mean, I just can't resist, because in the audience, we've got someone, Dr. Saul Mustafa. He's a colleague of mine. We've trained together. So, Saul, I want you to say hello to everybody.
I am very shy. Hello, Assalamu alaikum.
No, don't be shy.
Hello, Assalamu alaikum to all the audience. It's nice being here and nice to meet with Dr. Naseem again after many years. And that was, I've not got my camera on because I'm at work, so I'm just in the middle of a few things. But I think my only question was the application of the CCA-ARM. It's a good thing, and it's sort of something that any case, I was sort of saying it's applicable almost to any case, because you've got the fresh pair of eyes, having all the professionals. But I think looking at what Dr. Naseem said already about the family being central, that's quite a major point. And they are almost like the multi-professionals. They are the ones who act as we would in the UK. We'd have nurses or we'd have psychologists. There's family members who almost take on each of those roles. They may not have a positive behavioral support degree or anything like that, but some of the things that they do, and unfortunately some of the things that they do, like we've mentioned, locking in rooms, it doesn't just happen in Pakistan, it happens in the UK as well, even with all the safeguards and the laws in place. But sometimes that is something that they have to resort to because they haven't got any other option, or their knowledge is quite limited. I'm sure we'll hear a little bit more as we go on. But it was just down to that. It's the more people that you can get looking at an issue. Hopefully it's not the case of too many cooks spoil the broth, but they can help you to try and see a solution, or to see a way around something. But there's always that anxiety about what are we doing and is it helping the situation? And sometimes that aspect of sharing that is just, it's as important, because the doctor, he is always the center point, or he's the drug center point, or the team leader, captain, whatever you want to call it. But actually everyone plays a part in this role of trying to help the patient at the center of it. That's it. I'll shut up now.
Thank you, sir.
I must say that I'm working in Barry with Dr. Mustafa as well. So absolutely a pleasure having you here, Saul. So I think absolutely that's the thing about who is the right candidate and who is the right professional involved. So we do not need too many people to get things easy. It's just about, if we understand what's the story telling us, then you'll be able to say and deal with it. And again, as Professor Naseem said, that how in Pakistan, so much importance of having a family and care support, because when you're parents, it's different, but when you become carers, it's a really different process. And it's a really different journey for individuals who are parents, for carers for a number of years. And it's not just in Pakistan, we have heard a number of stories from here as well. When parents become carers, it's a different type of dynamics and it's a different type of provision. So how to improve that relationship as well as the caring responsibility. And that's another very important point to think about.
I also wonder if it's useful to think about, Saida, about the other part where you talk about the circle of support, that I think that lots of times we can automatically turn to the family, but actually we live in bigger systems and that we live in communities, and that often it's really important that we widen it so that, you know, like Sol was saying and you were saying, Saida, the more eyes on a situation, the better. So it might be not just the family, because you might become quite blinkered, you might be quite stressed or depressed by the situation, and sometimes it needs a fresh set of eyes that might be useful. So I wonder whether there is a need for gathering together other like-minded families in today's world, wherever you live. You know, there's the internet and phones, and you can create Facebook groups and stuff so that families can help each other. So there's not just your local community in the village you live in, but there could be an external community that's specifically for children with a specific need, and whether it be a communication need or a learning disability. It could be refined sometimes as time goes along. I don't know if that's useful to share.
No, absolutely. You're absolutely right. It's about how we are improving and how we are including them. And as you said, we don't have to restrict, because as we know, transforming care agenda, and people were institutionalized for a long period of time because the same eyes were looking after them for a very long time. But again, the transforming care agenda in UK is about how to transform their lives. And if we think similar things about as we talked about, Professor Naseem, about improving pathways in Pakistan, how to create pathways, so how to create a behavioral support pathway, or how to create a physical health or mental health pathway, and how to implement by just initiation could be helpful. Anything we may start with the first step, but it may be helpful to thinking about the pathways which we already started working on, and developing some focus group with Pakistan as well. So.
Thank you so much, Professor Sada Hussain, and that was a really very informative session that you have delivered to us, and a special thank to Mustafa as well, who has switched on his camera and give us a chance to see him. So moving towards, and we have to stick to the time, and that was a really very great discussion. I would like to move to take the session further, and for that purpose, I would like to invite Miss Megan Norris. Ms. Megan is current, and I would like to take the opportunity to introduce her. Megan is currently working as an assistant professor, clinical department of pediatrics at the Ohio State University, Columbus, Ohio. She is assistant professor, practice department of psychology, the Ohio State University. She is a psychologist at Child Developmental Center, Nationwide Children's Hospital. Last but not the least, she is the director of research, Child Developmental Center. So it's an honor for us to have an expert like you, Megan. So over to you.
Thank you so much for that introduction, and really that is, it's hard to follow that talk. That was a great informative talk, so thank you, Saida. It's validating though to hear some of the thoughts you shared, because I think that, and I hope and think that we overlap a bit in some of our thoughts. And what's resonating with me of what's been discussed so far is that this is all a process. We're all discussing the process that we're striving towards improving lives of people with intellectual and other neurodevelopmental disabilities, and that it takes time to make inroads and create those pathways. So hopefully I'll have some tidbits of knowledge to share. Hopefully I'll do this topic justice, and really grateful for the opportunity. So with that, am I screen sharing okay? And can you hear me okay? I've got the right slides up. It's okay, perfect.
Yeah, it's Dr. Megan. Please.
Yeah.
Okay, well, now I just need to figure out the best way to advance my slides and we'll be good. Okay, there we go. So really I have no disclosures to make, other than, again, my children might interrupt us, but hopefully that won't happen. And I'm giving sort of a shallow overview of several different things, but of course, happy to share more information about any of them as we go on. So I'm going to overview some of the clinical and research services available in my area and location, and then with an eye towards some disparities and ways to hopefully move towards reducing those disparities. So knowing that I'm beaming into you from a different part of the world, just thought I'd give a quick nod to sort of where I am. So that red state is Ohio. We're in the Midwest of the US. I'm centered in Columbus, Ohio, and that is really smack dab in the middle of the state, which is helpful because we do serve not just the state of Ohio at our clinic, but families come to us from much further afield. So from other states, from other parts of the country, and even from some other parts of the world for some specialized care. So Nationwide Children's Hospital, someone gave a nod to the fact that we're working within systems. It's a huge system. So we really are fortunate to have a tremendous amount of resources at our disposal. And part of our mission is to try and disseminate those resources to serve more people more broadly. So this is an academic pediatric medical center, very large. Again, we see over 1 million patients annually, large amount of staff, and we also have a very large research institute as part of the main hospital that is continuing to grow and does a lot of cutting edge research, which is exciting. So, I am, as was mentioned, housed at the Child Development Center. It is the program within Children's Hospital who our mission is specifically to serve those with neurodevelopmental disorders, so including intellectual disability, autism, specific genetic conditions, and really anything that kind of falls under that neurodevelopmental umbrella. We are a large interdisciplinary program, and we are one of the largest, if not the largest, neurodevelopmental assessment program in the country, in the US. We work closely with schools. We also really value family-centered care and patient-centered care. So these are some of our tenets that we really base all of our actions on. We offer a wide range of services, so both targeted and comprehensive assessment, evidence-based treatment, which I'll dig into a little bit more, care coordination, which has already been mentioned by one of our first speaker as being pretty important. So one of the things we've noticed in our clinic over the years is that we might do a very comprehensive, individualized assessment to try and help move a family forward to access services, but then accessing those services can be very challenging. And again, as already mentioned, it really sometimes falls on the family who might be stressed, who might live in an area where there's fewer resources available. So our care coordination services have really grown in recent years to try and address that need, because it does take, as they say, it takes a village. It does take a large number of people sometimes helping make those connections. We also have a lot of subspecialty clinic involvement. So as a psychologist within a medical center, we want to stay relevant to all of our colleagues. And we think that we have a lot to offer a lot of our medical colleagues. So the team-based approach is something that we embrace. And we're fortunate to be able to touch more lives that way. So I'll get a little bit more into what some of those clinics are. We also are involved in consultation and liaison services. So if a child, again, I work in the pediatric world. So if a child or adolescent is admitted to the hospital with a medical problem, like maybe they need surgery, but they have a neurodevelopmental disorder, we might be consulted to go down and help develop environmental strategies to support that child when they're undergoing their medical procedures. Or there might be a developmental question that hasn't been identified yet until they're in the hospital seeking services for a medical reason. So we can go down and consult and sometimes provide assessments while the child is inpatient so that they don't have to arrange to come back to further appointments. And of course, as the director of research at my program, I am very passionate about our research program, and I'll again hit on that briefly as well. So anyone within the children's system that has a question of a neurodevelopmental disorder or has an identified neurodevelopmental disorder is likely to be referred to us if they need some kind of support. So our intake appointments are really just to sit down with the family and get a good idea of what are your needs, what are your questions. Let's make sure we get you to the right place so that we can help sort of move you along the process towards whatever you need in your life. So from that, families are triaged to treatment or assessment, or maybe they didn't need to be at our clinic at all. Maybe they actually need to be with psychiatry or in a different part of the hospital, so we can help connect them there. Our interdisciplinary diagnostic assessments, or IDAs, this is our most comprehensive assessment. It's a nationally recognized model and has been replicated at other sites. It involves a two-part half-day assessment on each day with a medical provider that could be a developmental behavioral pediatrician or a neurologist or a psychiatrist, but a medical provider, a psychology provider, a speech and language provider, and a genetics counselor are all involved on that first day. So this is really for children and adolescents where a primary question might be autism spectrum disorder and or some other complexities involved in their presentation. The psychological evaluations are sometimes reevaluations. So often when we see a child young, we think it's important to monitor their development moving forward because we know that there's increased risk, as has already been pointed out, for individuals with intellectual disability or autism for developing other behavior or emotional difficulties in the future that they might need support for. So we do a lot of reevaluations to help again, monitor development and then make sure we're connecting families with what they might need as their child or adolescent grows and matures. We also have a lot of medical clinics that support sort of monitoring medical needs of our population, but also medication intervention, if that's a part of their treatment plan. And then we do a wide variety of treatment for this population, including behavior therapy, cognitive behavioral therapy, parent-child intervention therapy. We have specialists in feeding treatment, which is a huge need in this population. So this is something that needed to adapt a little bit during the pandemic, but is something that we've adapted for telehealth, and also can coach parents through working on some feeding goals when their child might have restricted feeding patterns. I already mentioned the care coordination, but all those different types of treatment, we have over 100 appointments of those a week. So we have a very large patient volume in our clinic, and part of that, again, is because of our values, and that we don't restrict who we will see. In terms of age, there's not an age limit, there's not a location restriction. So basically, if you need help and you're sort of a child or adolescent, then you can come to our clinic. Did want to just highlight, again, this will become relevant with some of the later things I discuss. This is a heat map of who we saw. This was pre-pandemic, so it would look a little different now. I suspect that we would have even greater sort of blurbs, for lack of a better word, more broadly spread out since the pandemic, since we've increased our telehealth. But that sort of biggest reddest blob is the Columbus area. I drew an extremely imprecise outline of the state of Ohio, so it's a much more squiggly state than that, but you can see that we're pushing into Kentucky and West Virginia. We have a pretty large Kentucky and West Virginia population because they don't have anywhere else to go. So families will travel 2, 4, 6 hours to see us to get what they need. And I cut out the map that showed you even sort of across the US that we certainly, again, see families from further afield as well. So the subspecialty clinics I mentioned, we have a psychology and CDC presence in a lot of different clinics throughout the hospital, some specific to genetic conditions like Prader-Willi syndrome or Williams syndrome. We also have psychologists embedded in the epilepsy clinic with our neurology colleagues, trying to monitor development and help provide behavioral recommendations for that population. The International Adoption Clinic. The one that I wanted to highlight for you all today is our inpatient consultation liaison. And the reason is because it's just very novel and very exciting for us. In the behavioral health world, we really are extremely fortunate to have opened a unique center within the last couple of years through the hospital called the Big Lots Behavioral Health Pavilion. It is a state-of-the-art center for children and adolescents that are experiencing mental health difficulties, behavioral and emotional difficulties, which again, we've already heard about sort of the different factors that are involved in that. So when I say difficulties, I mean they're presenting with a problem that they need support for. And so the BHP, as we call it, is the largest on a pediatric medical campus in the United States. It's the largest center dedicated exclusively to children and adolescents that are experiencing behavior and emotional difficulties. It has inpatient services, intensive outpatient services, research, care coordination, everything under one roof. And one of the things that I think is extremely exciting about it is that it's also a beautiful building. So in the US, at least historically, there's been a big stigma around mental health and mental health difficulties. But we also know that environment can impact mood and how people are behaving. So the BHP was really designed with lots of natural light, with safe outdoor spaces. So when families or children are inpatient, they can go out on a porch or play outside in an open area that is still safe and secure. And it's just really, I think, an impressive commitment to behavioral health, which is another trend we're seeing, is a huge commitment to supporting mental health across the board. And so one of the things that we at the Child Development Center are involved in is that there are 4 inpatient units in this building, and one of them is specific to those with neurodevelopmental.
Hello.
Hello? Yes. Sol, did you have something to say? Okay, I'm just going to continue. But there's a specific neurodevelopmental unit that's an inpatient unit for our children and adolescents with intellectual disability or autism or other neurodevelopmental problems that has a large team of interdisciplinary professionals to provide care for them when they're experiencing a mental health crisis. So again, wide range of services there. Very interdisciplinary work, getting to this idea of, not wanting too many cooks in the kitchen, as it were. I think that who needs to be involved is involved. So that's a team decision that also is a family decision in terms of what their goals are and what that child might need. So on the psychology front, my colleagues that are housed in that unit provide a lot of assessments. They do about 12 assessment consults a month on average. It varies, and a lot of intervention support as well. But again, a wealth of services, which is really exciting for these individuals that are in crisis and have high needs. I also just wanted to highlight that at the BHP, there is an emergency room specific for mental health concerns. So whereas the hospital has the general emergency room, if there's a medical crisis, the BHP has its own separate emergency room if there's no medical concern, but someone is having a behavioral, emotional, acute situation, so that they can be triaged and served within that environment with the people that are specially trained to help those difficulties. Sliding into the research, because this is close to my heart, I think that we are very fortunate to have a clinical research lab embedded within our center. So we have close contact with our families and patients in order to recruit and provide them with the opportunity to participate in research. We are a very, very applied lab. So our mission is really shaped by the people we serve and what we think they want and what they tell us they want, with an eye towards shaping better services. So we have at least one of our research coordinators on joining us today, which I'm grateful for, but we have some wonderful research coordinators, research fellows, but really the entire center, and even more broadly, the behavioral health leadership at hospitals supports this endeavor. And we have grown pretty quickly over the last 5 years. We have a lot of active projects, but I really wanted to focus on just one today called Project Echo, which, again, I think you'll hear similarities between what Saida was presenting, but certainly some differences as well. So Project Echo was originally started sort of in the medical realm, but it's been adapted for lots of different purposes. And I would encourage anyone who's interested to go to the University of New Mexico site for it if you're not familiar with it, because they have some wonderful online resources. It's all about pushing knowledge out. That is the main goal of ECHO. So that tagline there, moving knowledge, not patients, is really one of their primary tenets. And usually ECHOs, it's a hub and spoke model. So there's a hub team of professional experts, and then the folks at other sites, the participants as it were, are other professionals that are looking to gain additional knowledge on different subject areas by participating. So there is didactic case presentations, but also then the participants can bring cases as well to discuss and problem solve with the whole team. So it's really an everyone learns from everyone model. Participants are sort of learning from each other. The expert hub team is learning from participants, and then hopefully also participants are learning from the expert hub team. Again, just to push the information out. Ideally, so families don't have to travel 4 or 6 hours to a tertiary care center like we have in Columbus, but their primary care providers, for example, in their sort of town where they live can gain additional knowledge to serve them closer to home. So at NCH, we have a pretty robust echo program. We have some echoes that are specific to autism. Ruby is a parent training program that's evidence-based. So tries to help families gain more information to manage difficult behaviors or challenging behaviors, which again, Saida did a wonderful overview of that. So I second everything she said about sort of the term challenging behaviors. But, you know, I think that when we talk about, I think in general, people have best intentions, parents, families, professionals, but again, not knowing how to do something is very frustrating. And then you do the best you can, which can lead to not ideal ways of addressing some things, as we've already heard. So Ruby is one way to try and provide additional knowledge on managing the environment and how to manage the environment to help improve behavior and quality of life. There's also sort of more general behavioral health echoes, and even more broader than that, general pediatric health echoes run through our center. I do also want to point out the family echo series because it's quite unique. And what I described originally is sort of the more traditional echo model where it's professionals that are the participants, but the family echo series is for families. So, you know, it doesn't exclude professionals. We certainly have a lot of school personnel that join family echoes as well, but it's also really built and designed around parents and other family members of those with neurodevelopmental disorders and what do they want to hear more about. So it's probably our echo with the broadest reach and the most participation, which I think highlights the need and the interest there. The other wonderful thing about echo is that it's adaptable. So there's lots of other echoes in the works on various topics. I hope this, okay, there we go. I was going to say, I hope this animation works. But just to give you an idea of how echo has grown. So the blue dots are where people participated in 2019. Again, this is just site specific to us. There are definitely other clinics that run echoes. The orange is building on that 2019. So 2020 would include blue and orange, and then 2021 would include all three of the colors. So, so well over 30 states out of the 50 in the US have participated in these echoes. And that's probably an underestimate because the slide is a little bit old. And then the beauty of echo, again, is that it doesn't matter where you are. If you have access to telehealth, you can beam in. So we also have had an increase in international participation over the years. The blue star is roughly where we are at the center in Ohio. So it's really exciting, and all are invited to participate, really. How am I doing on time? I don't know. I'll go really quick here. So just a quick nod to sort of disparity in areas for growth, which is, you know, my specific areas of interest are assessment and research around assessment. So very briefly, just speaking to some areas of need in our field, but we know that we have limited instruments that can measure precisely and accurately with lower IQs or with when someone has less language. So I really think sort of moving forward, we need to be thinking about how we can improve that because it does complicate differential diagnosis and it does have implications for services and access to services. And then we know within the research realm that the field overall is got a lot of room for improvement in terms of including people with lower IQs, with limited language levels, both in general research, general medical research, but also within the autism spectrum research area. We know that folks with intellectual disability are underrepresented, which has some pretty significant implications for generalizing results and understanding both intellectual disability and autism spectrum disorder. So moving forward, telehealth is a big thing that we're leveraging, and I think will continue to be important. And again, as we heard in the first talk as well, we really needed to pivot quickly during the sort of stay-at-home orders to make sure that our families and patients were still able to access services. So we were able to transition almost all of our clinical processes to telehealth within 2 to 3 weeks. So we had very little lag time at the start of the pandemic, and now we're back to in-clinic largely, but we have that option available. I do also want to point out, though, that this telehealth doesn't work for everybody. So it's great if you have access to internet and reliable internet, but there's a lot of areas in Ohio included that do not. So there's still some problem solving to be done there. And then inclusion in research, I think this will require a paradigm shift from a lot of different stakeholders. But I wanted to highlight one example from our lab that was successful in including underrepresented populations. So this was a treatment study, basically trying to improve oral care in people with autism spectrum. And as you can see, we had a pretty high portion of individuals with intellectual disability and pretty high retention rate as well. So, you know, I didn't present the satisfaction rates, but those were also quite strong. So lots of acknowledgements, you know, no one works in isolation, and lots of citations. I was kind of hoping that, you know, we might be able to make the slides available afterwards. So the end, happy to take any questions. Thank you for your attention. Sorry if I talk quickly.
Megan, you took us to this world of where, you know, you would aspire to just have 1% of what you've got. But what impressed me, Megan, and what your passion, I mean, it just flows through that what it means to you, and what an amazing work you guys are doing. So very impressive.
I appreciate that. And yes, we're very passionate. We know we are very fortunate, but it has taken time to build up these services and a lot of support. So, so we are also passionate about sharing any knowledge we might have with others that might be helpful.
Sada.
No, I must say it's excellent. I think it's very impressive framework and structure, especially the way it has developed. I was looking at the enclosed area where children were playing, you know, so much thoughtfulness around their needs, you know, what is important for bringing them together for the environment, for the social participation point of view. Excellent work. And I'll go through your citations as well to read a few papers, what you've done as well. So thank you so much for sharing it.
Any more comments, questions for Megan?
Hi, Megan, it's Jill. I'm just really impressed at how many areas you've been able to get out to, you know, and how quickly you were able to convert an in-clinic face-to-face to being virtual during COVID. I think, yeah, we probably all got a lot to learn from that. But also that issue, like you said, even close by in Ohio, some people don't have the access to the internet. In England, we call it digital poverty. And there's a lot of digital poverty in the learning disability population. So during COVID for us, we were standing outside people's houses, passing them an iPad so that we could talk to them from the car. So we could still do interventions that weren't in the house, but was as close as possible. And of course, clean down the equipment afterwards and all the rest of it. Right. But, you know, it is challenging, isn't it? But it was really nice seeing your map of how far you've been able to extend things from that smaller map to begin with. It was so much more, wasn't it? And I think that, you know, when we think about Pakistan and their large geographical area, and it's useful, very.
Yeah, and I was thinking about the ECHO one as well. It's quite something which we are doing in terms of in the form of CALM or NWLE forum, like presenting a case, thinking about what could be the recommendations and bringing it back to the people who are involved. So it's quite a lot of, I can see those things resonating in our practices and services as well. And it's excellent program, ECHO is. It sounds like a lot of learning, a lot of including people with lived experiences and, you know, those sort of things. I think it's quite impressive. And I think it's going a similar type of frameworks here, but it's quite impressive the way it's been shared all over the, you know, state. So excellent.
Any more comments?
Wonderful presentation and amazing work you have been going on. And I must tell you that Ruby, we are actually adapting and in our Pakistan. So Dr. Karen Beer, she is an amazing person, and
Yes.
we are working with her on this manual. So hopefully we will include other person. And I must appreciate your behavioral health model, and I'll talk to you more about this in email, inshallah.
Happy to talk more, anyone. Thank you so much.
And we are truly honored to have you, and I'm so much grateful because it's your early morning and I'm feeling guilty that it's time for school kids. So,
Okay.
but you are very passionate and enthusiastic, and this is your dedication with your work that you are sharing your knowledge with us. So now we are another eminent speaker and inspiring person with us, Dr. Jill Mcgeary. She is a chartered clinical psychologist and registered with the Healthcare Professions Council. She is also registered with the British Psychological Society, and she is a member of Division of Clinical Psychology and the Learning Disability Faculty of the DCP. She has an experience of more than 25 years, and she has built up substantial research in clinical assessment, psychological therapy in both qualitative and quantitative research, along with delivering training to universities, care providers, families, and health and social care teams. Since qualifying as a clinical psychologist, she has provided consultation, professional support, strategic advice to health teams, management of professionals, and carried out clinical supervision to psychologists and allied health professionals. So during the past 5 years, she has volunteered her professional expertise to a local organization, Sure Start for Later Life, and we are very much blessed to have her because she is also collaborating with Pakistan Institute of Living and Learning from the past 5 years. So Dr. Jill has received additional training in sleep from Oxford University and the sleep clinic. She is also trained in mindfulness. She is expert in family systematic therapy from bereavement, positive behavior support. And so this is all about, and it's a huge list to describe your work. So incredible person you are, Masha. So now I won't take your much time because your topic is very interesting. So please go ahead.
Hi everybody, can you hear me first of all? Great, thank you. Oh, it's a pleasure to be here and to see so many names. I can't see there's 39 people here, so it's great to be able to connect with so many people and to share some important work and to reiterate really, you know, what Nadia and Nazim were saying at the beginning, that you know, there's a lack of knowledge out there for the work that needs to be done for people with learning disabilities. And my talk is going to be focusing on the history of learning disabilities work in the UK, because I think sometimes we can learn from history and we can learn what to replicate and what not to replicate. That would be really important. So yeah, some of the things that Saida and Megan have been talking about are the things that we hugely want to replicate, but maybe I'll be explaining some of the things that we might not want to replicate, but also some of the political things that are really important. We often think as clinicians, we don't get involved in politics, but you know, the funding of places like Megan's fantastic building and facilities and rooms, needs a lot of political hammering, levying, whatever the word is. So yeah, so perhaps I'll just get on and share my slides. Okay, can everyone see that? Yeah, grand. So yeah, so I'm just going to go through a tour of what's happened. It does touch on other countries very slightly, but it's mainly about what's happened in the UK over the century, really, or 2 centuries. So we'll just go, oh, why is my screen not sharing? Yeah, there it is now. Okay, so to begin with, when we think about the lives of people with learning disabilities in the last century, we were thinking about people working in villages. We didn't have modern machinery, we didn't have factories, we didn't have fossil fuels. You know, it was definitely living in small villages, living off the land. And for people with mild to moderate learning disabilities, they often fared quite well because they could work on the land, they could be supported to do things within the community, baking in the kitchen, helping out in other areas of life. But for those with profound learning difficulties and disabilities, it was really, really difficult. It meant that often they were homeless, they were rejected by their society, and often died early because they weren't supported. For those with mild and moderate learning disabilities, there are cases of people taking part in circuses where they were seen as freaks to be used for entertainment. I don't know if any of you have seen the Greatest Showman, and how much, you know, that emphasizes how, yeah, we did in the UK and America and across Europe have shows where we used people to show their differences in a very negative and horrible way, and how actually the people within those circus communities came together and actually found some value in themselves and created their own community. But yeah, it really was not a nice life for people with learning disabilities, whether it be profound, mild or moderate at the beginning of the century. Then what happened was we started to have factories, we started to have towns that were developing and people coming together to do things on bigger scale, so they become more efficient and more effective and a lot faster and saving a lot more money. But what that meant was that some people with profound learning disabilities couldn't find a role in life, they couldn't find a purpose, and they were not supported by their families and their communities because they'd perhaps be working in factories or working in another building or working in a big family home, so that they weren't near their family loved ones to be able to support them to be fed and to keep themselves safe and to look after their bodies. So actually what ended up happening was lots of people with profound learning disabilities started moving into big institutions. And as the century carried on from the 1845s onwards, we started to get legislation in place that segregated people because of their inability to work in the way that the big organisations at the time wanted them to. So we had some terrible laws that were brought into place, things called the Idiots Act, Asylum for the Idiots, Feebly Minded. And this all then culminated at the beginning of the 19th century into the formation of a thing called the Eugenics movement. And not only did the UK take part in eugenics, but America did and Europe did. There was a chairman in 1930, I'm just going to read out his quote, who was called Julian Huxley, and he was the chairman of the Eugenics Society for the UK. And he said, what are we going to do with every defective man, woman and child? Every defective is a burden, a big burden, an extra mouth to feed, to clothe and care for, but produce little or nothing in return. So yeah, that's a whole terrible focus and derogatory language and understanding that was being developed, because everything back in those days was about being productive. And actually today, you know, there's lots to do with that still, and whether that be in the UK or Europe or beyond, that productivity is sometimes seen as the biggest thing. But I loved what Megan was talking about before. You know, we need to talk about people's well-being. Today, people are talking about behavioural science. You know, how can we make quality of life better, because if we have good quality of life, we're using the services less, and we can give back to society as much as possible. But yeah, back then in the 1930s, things were really dire across the whole of Europe and into America. And what did happen around that time was we had the First World War. So masses of soldiers were sent across Europe to fight in wars and to stop the invasion of certain areas of Europe. I don't know how much people know about this, but thousands of men were killed during this First World War, and thousands were injured. And when they came back to England with their injuries, there was a big movement, a political movement, to enable those that came back to get services. So prosthetics became popular, heart conditions were looked after. Even that was the start of thinking about post-traumatic stress disorder was beginning to be thought through. But what that did do for the people with learning disabilities was to segregate them more. There was a complete divide between those with physical health problems and those that had done something really productive in the past, compared to those that weren't doing anything productive in the way of making things and offering things to society in a very physical way. And learning disabilities was one of the main ones, as well as mental health. So there was a whole segregation and still a real stigma, a real lack of support, lack of resources, and a locking away. So many of the institutions actually grew, and many of the institutions that in the past had helped people with physical disabilities were filled with more people with learning disabilities and mental health problems. And actually it began to incorporate people with mild and moderate, the definitions that Saida were talking about at the beginning, ended up being in those big institutions, because as society got cleverer with machinery and ideas and processes, it meant that more people with mild and moderate were going to be struggling to live in that kind of society without support and without understanding what they can also offer to the world. I've just got a little clip to show you. So what we do, I don't know if you can see these two pieces of information clearly. The one on the left is a document from Ellis Island, and that shows that actually when people travelled from the UK and Europe to New York to be an immigrant and to want to start a new fresh life, they had to go to Ellis Island to be processed. And if they went there, they then had to be tested to see America. And they actually did IQ assessments and looking at whether somebody had a mental impairment. And if you had a mental impairment, you were not allowed into the country. So can you imagine whole families had saved money, had travelled distances like they do today to countries in the hope of having a better future. And when they got to Ellis Island, the rest of the family could be accepted, but the person with a learning disability would have been sent back. So the big decisions that will have to be made by an individual about whether, and their family about whether they would go back with their loved one, and that the one they're sending back was the least able to be able to function and survive the going back. So whole families were ripped apart, a whole load of extra trauma was experienced at a time when they were probably feeling quite hopeful and had spent a lot of money and energy and taken a lot of risk to go to a country where things they were hoping were going to get better. The other bit on the right-hand side is a document about what happened during the Second World War. So back in autumn in 1939, Adolf Hitler secretly authorized the medical administration program called the Mercy Deaths. And that was an operation whereby they killed thousands of people with learning disabilities because they didn't fit the ideal idea of what a human should look like. By 1941, approximately 70,000 Austrian and German disabled people were killed due to this program. So what did happen was the world found out about it, and it stopped, but it didn't stop physically. It stopped being published and being talked about. It just went undercover. So often when you think about Auschwitz and what was happening during the Second World War, you don't realise how much also there was a massive population of people with learning disabilities being killed because, again, they were a group that weren't accepted. You might wonder why I'm talking about this, but this has a real relevance because it has had an impact on how people with learning disabilities are seen within Europe. Because what happened because of, let me move on to the next slide, because of the war, when it stopped, we began to think about the human rights of people. So unlike World War I, where we were just thinking about people that have been physically hurt by the war, we were also thinking about all the Jewish people, all the Gypsy people, all the Slovakian people that had been killed. And actually, we need to think about, it's not just one group we needed to protect and support. It was a human right to be treated as an individual and accepted and be supported, and your life to be as important as everybody else's. So we now have human rights, and that human rights incorporated people with learning disabilities. How could all those people that were rejected by Adolf Hitler and his crazy eugenics idea of the perfect race not include somebody with a learning disability? We needed to make sure that a learning disability was accepted as a human condition, and the person is beyond that disability that needs to be accepted and valued within society. So yeah, the next clip shows you a little bit about the institutions that did exist within the UK around the time of the Second World War and beyond. So although we did have this human rights drive towards treating everybody equally, everybody having the right to no slavery, to having liberty, to a fair trial, to no torture or inhumane, degrading treatment, lots of different human rights. Actually, the reality in the UK was we were moving towards it, but it takes a long time. And I don't know if this is useful for Pakistan and other countries to know that these processes don't take as quick as we think. You know, we did have big institutions carry on after the Second World War. And in fact, for a little while, they grew. And these two, you might want to take down these YouTube clips because I haven't got time to show them to you. But these are the big institutions that existed for people with learning disabilities in the 1950s and 60s, where people with learning disabilities were treated in a degrading way and they were tortured. But I think it's, as Saida and Megan have talked about, it wasn't that individuals wanted to do it. You know, Nazim talked right at the very beginning about locked doors, people locking people up in their own homes because they had no alternative. It was the same in these big institutions. You know, the nurses and the doctors will talk about the fact that, you know, there will have been thousands of people there and few professionals to be able to do a job. So what can you do on a big scale? And there's some really lovely clips within these two YouTubes that you can have a look about how they tried their best, but things just failed, and that actually having big institutions is not the way to go. That actually we do need to put resources like Megan's institution and others where we have a lot more staff that can help and support. So yeah, so this is just a really nice few little interviews that were done with people that worked in big institutions just before they closed, because we wanted to capture what was happening in those institutions. And I think the middle quote is really useful. I often use this to explain what happens with institutionalization when you have people placed in big places and they don't have the support and the staff to be able to make changes and to work with them for a better quality of life. So yeah, so this is what one of the nurses talked about. So the first ward, a children's ward that I went on, nobody had a toothbrush, nobody had any shoelaces. So it meant they couldn't walk anywhere because they had no shoes. Everybody had hospital lace-up shoes, but they couldn't go out anywhere. So one of the first things that I did when I got there was to go to the store and ask for 25 toothbrushes and 25 sets of shoelaces. And the storeman said, "We've never had an order like that. It's not on the supply list." So there wasn't any expectation, and there hadn't been. Nobody bothered. The expectation was something crazy like somebody eats shoelaces on that ward, so we're not bothering replacing them because they'll just get eaten again. So it is a case of, you know, certain processes and policies and practices begin to be bred when we have big institutions where actually economies of scale become more important than the actual individuals. So what we did begin to do and realise, because of Second World War and the need to think about people's human rights, and the voices of people with learning disabilities was being heard, was there was a decision, and the voices of people with mental health problems were beginning to be heard as well. So there were campaigns for people not to live in big institutions. So that led to smaller mini institutions occurring, and that people were thought of as needing to live in smaller houses, but those were still sometimes rather large. So it might have been a home for 30 people. And they didn't think about, are they going to live closer to their families or the communities that they had been moved out of? And are we going to hear them, or are we just still going to lock them up and not know what they want? But actually what did begin to come out of that, as we began to realise some of the institutions that were being replaced from being large to only 30 wasn't giving us what we needed, wasn't actually helping people have good quality of life, we were beginning to realise that actually what we needed was people to be seen as individuals with their own personal strengths and qualities, which fits in greatly with what Saida was talking in her in the first lecture. So what we began to have in the UK was several acts. It was first the Community Care Act in the 1990s, where there were major reforms of the NHS. They were thinking about what can we do to support people in different ways in the local community. And it meant that how are we going to pull resources together? It meant how health boards are going to put some money to one side, and how are the local councils going to work together to be able to improve the health of people with learning disabilities. And I don't know whether thinking about that in the form of Pakistan, whether there are similar bodies that would be useful we need to think, how are they going to come together to be able to make some of the changes that are required? Because you can make changes on an individual level, but actually sometimes you need resources. For us in the UK, it was about moving resources. It was about closing the big institutions and taking that money and those buildings and that property and selling it, and think about how can we use those resources differently. So it'll probably be different from Pakistan in that effect, but it is important that you think about what resources are there and how can they be shifted to get the best possible outcome for the individuals. So then what actually happened in the UK was we were beginning to think, how can we get the different professions that were working in those big institutions and the new ones that were coming through, like speech and language therapists and OTs and physiotherapists, to work together. And what we began to do was to create what we call now is a CLDT. So that's a community learning disability team. But in each area, it varied, and commissioners had different ideas about what was important for that community learning disability team to focus on. And sometimes our commissioners didn't know what they were commissioning. They didn't even know what to ask for. And some of the commissioning wasn't just for learning disabilities, it was being used. We had commissioners for substance misuse, we had commissioners for older adults and physical disability, and often learning disability might be lumped with them. So actually the expertise was lacking. So those with the money, it's really important that we don't make those mistakes, and that we actually need to educate our commissioners today, is what we often talk about, in what is important to the population of learning disabilities, because it is different to older adults, it is different to physical disability and substance misuse, or any other area that you'd want to do joint commissioning on. And then we need to think about moving on to how actually would we support people with learning with disability to live in the community. Now, I don't know if any of you have heard of Wolfensberger. He is, I think he's actually from Canada. Is that right, Megan? Do you know? No? But I think he might be. But he actually gave us a great framework to work with as we were moving out of the big institutions and beginning to think of people not living in mini institutions, but actually living in their local area, living in communities, living in small houses. In Salford, where I worked for quite a long time, we often talked about living in ordinary streets, in ordinary houses, and we had a limit of 3 to 5 people living together, because actually the bigger the number, the bigger likelihood is that you're going to start looking at economies of scale and how can you do things cheaper or quicker because you've got more people, and then you lose that individual aspect that I was talking about before. But Wolfensberger created a term called social role valorization. And this is about holding in mind what actual social role a person can have. so that they can have good meaning in their life and that others can see them in a positive way. So I often think about social role valorization when I think about some of the guys that we worked with in learning disabilities in Salford. A few of them worked in a conservation project for a very old Edwardian house that had been restored, and they were part of the team that did that restoration. They were part of the team that worked in the cafe. They were part of the team that worked in the gardens. And actually what role they brought to that team wasn't just their ability to do some of those jobs in restoration and gardening and baking in the kitchen. It was actually lots more. And they brought along a sense of community because they actually were listening to people when everybody else was busy off doing their work and focused on whatever they were doing. Actually, often the three guys that were working in that restoration project had an eye on everybody. They weren't bothered about the facts and the figures and the information and how clever people were. They were actually really impressed by the individuals and wanted to bring people together. They were often the best communicators about how to share a common goal. They were often the ones that actually remembered to bring the milk in, so everybody, all the volunteers had stuff. They were often the ones that remembered where the keys were when everybody would have forgotten. So a social role is so much more than just a job to do. It's a whole sense of them as a being and what they can offer to a community. And then Wolfensberger definition of how and a model of how we can help people with learning disabilities be supported better in the community was extended by a gentleman called John O'Brien, and he really nicely broke it down into 5 areas that we need to think about when we're trying to give people with a learning disability the best quality of life living in the community rather than in institutions. And his first one is community presence. So how can we make sure they've got a presence? So often we would talk about, are people with learning disabilities getting in cars to go places? Are they just doing things in their house? But what would be better? Are they getting on buses? Are they catching trains? Are they integrating with others? You know, because how many times do we chat when we're waiting for a bus? And you might meet somebody while you're chatting on the bus or on the train that you all of a sudden realize you've got something in common, or you just have a good affinity and a good conversation for 5 or 10 minutes. Then the next point that John O'Brien made was that we need not just community presence, but community participation. That's about actually taking part in things and doing things rather than just being there. So it's a bit like that project I described, you know, they were actually engaged in doing some of the valuable work so that people were seen to have a role that was actually would be missed if they weren't there, that there would be a hole within the work that was happening without them. And yeah, that the relationships are as important as actual productivity that was happening. When you think about the beginning of the lecture, I was talking about productivity. Productivity only really works when people have got really good relationships with each other. And that's what's needed, is it's participation, not just presence. There's no point just taking somebody to an event like we used to do. We used to just take them somewhere and get them to, I don't know, weave baskets at one point that had no value to society at all. But real participation is important. Then we need to encourage those valued roles. We need to enhance the reputation. So there needs to be some political push towards getting out those positive images of people with learning disabilities. It can't be that we just let it happen and it evolve, because it will take longer. It's about increasing that reputation for the group of people with learning disabilities. And then John O'Brien talked about promoting choice so that people with learning disabilities aren't just seen in the community and are getting a positive spin on the work that they do. I think about some of the people that we now have in learning disabilities. We have quite a few actors and actresses with learning disabilities. We even now have an air hostess that's got Down syndrome, and she's been quite vocal in Facebook and in social media. However, there have been a couple of comments about, actually, has this lady got choice in that? Is other people using her and promoting her? What kind of things does she do at home? What kind of things is she doing in her life? So there's a balance, isn't there, between that social role for the bigger good, but also making sure on an individual level there's a sense of choice because we have to think about the individual's well-being as well as the bigger picture. And then the last point he made was supporting contribution, and that's about thinking about their competencies. So that really fits in with what Megan was talking about, you know, looking and assessing what skills somebody has and making sure we work towards the strengths that an individual has, because we're actually going to choose with them roles and participation that is to their best and actually can extend and develop over time if we're actually thinking about what somebody's abilities are and what contribution they can make with those abilities in mind, and stretch those abilities so that they have a sense of achievement like the rest of society. They have a sense of accomplishment, a sense of receiving certificates. I often have spoken to people with learning disabilities in their houses, and on occasion they'll point to images of brothers and sisters receiving certificates and trophies, and even the pictures of people getting their degrees in their gowns and things like that. And actually today I've seen quite a few people with learning disabilities with their trophies for the Special Olympics, with trophies and signs on their walls and certificates, showing how much they've actually achieved themselves and contributed to different communities, different projects. But the other thing those were the things that John O'Brien and Wolfensberger set out. And I think if nothing else that you remember from my talk are those two models as a way forward and a really important message. However, I'm just going to explain, I'm going to whistle through the next few bits because I haven't got much time. Around, even though we had those great models, we did still slip back in the UK into some really poor practice. So we did have in 2006, I think called the Cornwall Inquiry. It was where we actually uncovered that there were thousands of people with learning disabilities being treated poorly, being abused, being locked up, being bound to chairs, not being given facilities to wash and clean themselves, pictures of people being slapped in the face. So really poor practice. Even though we had some really good models, it's also important to make sure that we have got good eyes and ears on the ground and a good way of listening and hearing what people with learning disabilities want. So the importance of focus groups, the importance of service user voice is going to be so important as services get developed. So that happened in 2006, and we thought we would have learned from that, and we did. We put plenty of practices and policies and interventions in place, hoping it wouldn't happen again. But we did. We had another inquiry, Merton and Sutton, and then more recently, one that's quite well known in the UK at least is Winterbourne, and then more recently, 3-4 years ago, we had Wharton Hall as well. So it's just to keep an eye on the fact that, you know, no matter how much learning we do, no matter how much practice is put in place, we do need to keep an eye on making sure that these institutions don't creep back in, because when you look at all of these inquiries, they were all about institutions being created. So yeah, if you want to have a look, like I said before, there isn't much time to show clips, there is that YouTube. I don't know if you want to take a quick photo of that so that they can have a look later, but it actually explains what was happening in Winterbourne. And the abuse there was described as being similar to torture in Guantanamo Bay. So there was waterboarding, torture happening by the carers in that place. And actually a couple of the inpatients that were there had actually called the police to say about what the horrific conditions were and what was happening. And the police attended on those occasions, but they actually spoke to the staff and they didn't go and see the people on the ward. And the staff that they spoke to were the ones that were doing the abusing. And actually what did begin to happen was every Friday night, the police would go to Winterbourne inpatient unit and chat to the staff because they would get these phone calls regularly, but nothing ever changed because they didn't realise it was happening because they didn't speak to the individuals. So one of the other clear messages is you really need to speak to your service users, to the people with learning disabilities, to find out specifically what is happening for them and what would be in their best interest moving forward. And I don't know whether it's useful at some point to look up some of the great documents that have been created that have moved our services forward. That means we no longer have massive, big institutions. There's a document called Valuing People and Valuing People Now, and a gentleman called Jim Mansell who wrote some great reports around the way forward, because if we create big institutions, it's just soaking up money. It's not actually improving services. So there's a couple of documents he wrote in 2007 and 2010, one called Services for people with learning disabilities and challenging behaviour or mental health needs. But the second one is a really good document. It's called Raising Our Sights, and it's all about how can we transform services so that they're actually focused on supporting the individual and thinking about the qualities they have and the strengths that they have, that they can live as full and a meaningful life and contributing to the community. And then because of Winterbourne and Wharton Hall enquiries, we now have in the UK a government guidance called Transforming Care, and that fits in really nicely with the work that Saida was talking about. How can we pull all the professionals together, all the advice and support that exists, so that we can actually make some changes on an individual level, but also we can pool all our resources so we're not using big institutions and moving people away from their local communities and away from their families, but we're actually using that money to actually improve care locally. We often talk about it like a bath, that if we can turn the tap off of sending people, we can take the plug out, sorry, and not send people to big institutions and let them flow back into community. But if we don't turn the tap off as well, the bath will always be full. So if we're constantly putting people back in those big institutions, then it's not going to change. So we really need to be more proactive at making sure we've got the services in more local areas, rather than thinking that bigger and centralising is the best way forward. So what we have got now in the UK are several acts that is about combining health and social care, and we have vanguard sites that are leading on improving the combining of health and social care. And I think that's a really important aspect to take into consideration, that we're not just thinking about the health of individuals with learning disability, but we're also thinking about their social care needs, and that we have to share knowledge and we have to share skills, and we have to work together to develop processes so that individuals can get the best care that they need and support, and not just for them, but for their families and their communities as well. So yeah, I've come to the end of the information I wanted to share with you, and just hopefully having some of the background of, I know it might sound like I've described some really awful things, but I do think that we have to learn from history, and that we have to be mindful that it's easy to go down the wrong path. I think Sol was talking right at the beginning about labelling, and that it not always being a good thing, and we always need to keep those things in mind as well. So yeah, thanks very much everyone for listening, and there may be some questions. We should have time, is that right, to have a few questions?
Thank you, Jill. Thank you very much. You know how Megan took us into this world of aspiration and what we want. I think it's so important to also go through things that we would never want now, that should never happen again. So fantastic for taking us through this whole history of, very quickly for people, I know short of time, but I have to tell them that Jill is not just a colleague, she's a dear friend. Jill is someone who I've worked with for like 13, 14 years. She's the one who came to Pakistan, gave her time, developed learning modules for learning disability. We did some great basic training in medical school, some of our medical colleges. We've done a study which is being published on mindfulness that Jill has helped us with, for people with intellectual disabilities. Jill has twice come to Sharjah with us to provide training. So Jill, thank you for all that. And questions, comments, please.
I'll just quickly share. I think absolutely amazing, the journey, UK journey you have shared, how things evolved to become a CLDT, that how things can be easily dislocated, and how beautiful things can bring it back together. So we have to think about, again, evaluation and reviewing this process. But again, for personally, I've worked with Jill in a number of ways, you know, from academic side as part of PILS and also part of UK GMMH. So thank you so much, Jill, for being there always. You have been very kind, providing all your support and help for people who have needs with different difficulties, you know. So thank you so much. I think it's been really kind of you.
Oh, it's nice of you both to say, because I think I've brought doom and gloom to the whole thing. But perhaps me and Megan should have swapped. So yeah, thank you very much for saying those really nice things. Yeah, but I think, yeah, I wouldn't not say it, because I think it's important.
It is important, yeah. And we have to keep reminding ourselves about it. Yeah.
Do we have any more comments, questions? Nadia, over to you. Oh, Saul, you want to say something?
Yeah, it was just one comment just at the end, because I know that Jill's presented really quite well on this. But I think whenever we're dealing with people who are less fortunate or less able, there is that temptation to, not only with people with a learning disability, but other conditions, to sort of do things, and we think we're always doing the right thing. And I think the main question is to always question that. What are we doing here? Has that person got a say in this? Because at the end of the day, even during lockdown, we talk about these patients. We've talked, this is the center point, but a lot of times these patients, they don't have that access to actually be at the center of the story, and they are the center of the whole story. They're the ones who suffer. They're the ones who take the medication. They're the ones, even though they've got better healthcare, they're still dying younger. And there's lots of decisions that we make, and lots of things in a family situation. I was going to sort of raise the question, because the things that happened at Winterbourne View and other places, sometimes in other places, because you have different viewpoints as to what actually is restriction or sort of the care aspect, that as long as someone gets food and they've got a roof over their head, that seems to be enough in some occasions. And what else is filling in that time? We have restrictions in the UK, there are restrictions in Pakistan, in every single country. But if someone's hurting themselves, that's just to throw out as a question, and you're restraining them, whether you're like, as Saida mentioned, restraining them with medication, restraining them with rope, or locking the door, there's a difference in what you've got available, but also what you're trying to do as well in those situations. Just because we may have more money or resources and we've got different ways of approaching it, sometimes there is that difficulty into actually, I think it's all in all of medicine. Are we doing the right thing at this point in time? And it sort of brings into focus, especially when people are not only at the beginning of life, but at the end of life. That's when lots of these questions start arising. So it's just a general comment, just so that to get people thinking, because I think we've heard a lot of things about how things are. We've heard lots of great services and great models, but sometimes it is that fundamental thing as to what are you actually doing as whether it's a clinician, whether it's someone who's supporting, whether it's someone just providing any input, and really to keep focused that that person is at the center of everything, where actually we have relevance, but in some ways we are irrelevant as well.
Yeah, I agree with you, Saul. I think that, you know, hearing people with learning disabilities needs from them as an individual rather than what other people might say about it, finding the means to be able to do that is really, really important. And we'll only improve things by knowing what that person wants.
Yeah, and I think it's very important to involve them in terms of what we are doing with them. So in terms of care planning, in terms of what activities they are doing, do they like it, or is it something we feel they like it, or they live it? So yeah, involving them, I think it's really important and targeted to understand what's happened. And again, as you said in Winterbourne case, I think we were lacking that thing, you know, that touch, that physical touch, that touch about the environment of that individual by facing him rather than facing the carers and staff of the families. Yeah.
Just a quick follow up on that.
Please.
No, yeah, just sorry, quickly follow up on that. I really appreciate the sort of the really challenged to continue critical thinking, is sort of what I heard in your message about always sort of having a questioning attitude and keeping the person at the center, because they, you know, that's what's most important, but also it's going to be different for everyone too. So that individualization piece is quite important.
Any more comments? Because I think this really nicely concludes with Saul's comment and then Megan and Saida and Jill's views, I think. And I'd like to just conclude and end with
something went wrong. Please.
A big thank you to everybody, to our speakers, to Nadia for organizing this, Aisha for coordinating with Nadia. So, yeah. So thank you all. So we'll keep